Wonderful. Thank you so much, Selena, for that warm introduction. And more importantly, thank you for the invitation. I really, I don't feel like I'm an attending quite yet, because just 6 months ago, I was a fellow. But I love the energy of all the medical students, the residents, the postdocs that I've had a chance to see here at UCI. So whenever there's an opportunity to share my experiences with you, I'm always excited. I'm deeply passionate about my profession and what I do, and deeply passionate about skull base and cranial surgery and neuro-oncology. So hopefully this is a convergence for all of us to be inspired and to share with you my journey. And I was initially tasked with this title, Introduction to Cranial and Skull-Based Surgery. But I found this to be really the more appropriate title for this talk. And many of you are contemplating either a career in neurosurgery or know absolutely that this is what you want to do. And so I want to validate you. I want to share with you my experience, my stories, my ups and downs, my training. And if this connects with you, then you're on the right path, and reach out to me, reach out to any of your mentors, and continue the path, because this is a very, very rewarding profession. And it's a life of service. It's a life of constant learning. And I think if you're built this way, you are going to love what you do. It's hard work, but you will love what you do. They say a picture is 1,000 words. So this is my one slide that's going to give you my 1,000 words all in one picture. I just recently graduated from fellowship training with, as you see here, Juan Fernandez Miranda, both of us operating together on a posterior fossa case using an endoscope. Before that, I was a resident at the Ohio State University, where I spent 7 years doing my neurosurgical residency under wonderful mentorship from multiple mentors. But specifically with Danny Prevedello, a pioneer in skull-based surgery, and somebody who both I call as a friend and a dear mentor, just the same as I did with Dr. Juan Fernandez Miranda. Danny, I ended up staying another year to do a dedicated fellowship with him, and I realized very early on that skull-based surgery is a highly, highly technical field. And I reached to really somebody who has advanced the field like no other in skull-based surgery, particularly in endoscopic techniques, and that was Juan Fernandez Miranda. I emailed him a very, very lengthy email describing why I want to do this, why I want to do a second fellowship. He invited me out, I gave a talk, and that's how my career has been advanced by these two incredible mentors. I'm incredibly indebted to them. I would not be the neurosurgeon I am today without their training and what they taught me both in the OR and outside of the OR. But my roots actually are very humble. Like many of us, I came to this country at a very young age. I grew up in Cairo. I was born in Cairo, Egypt, and I came to this country at the age of 7. I'm pictured here with my brother. We settled in Detroit, Michigan, grew up playing a lot of sports. Soccer was a deeply passionate sport that I was excited about. I continued to play that as an undergraduate at Emory University, where it offered me an opportunity to excel with scholarships. But Emory gave me the perfect environment to grow as an individual, to learn about neuroscience. That year, when I started my undergraduate career, was the first year Emory was offering neuroscience as a major. So this was a very exciting time. I ended up doing research at the Yerkes Primate Research Institute at Emory there with an incredible mentor by the name of Jim Wilson. He was actually studying visual processing at the level of the lateral geniculate. And because of that, he introduced me to neurosurgery for the very first time. I applied to a position in his lab where he needed an undergraduate to help assist in monkey surgeries, where we were implanting electrodes at the level at the lateral geniculate. And that was my first introduction to neurosurgery and science together. And I was hooked. He encouraged me to apply to MD PhD programs, and I did. And in my first round of applying to medical school and to MD PhD programs in particular, I unfortunately did not get accepted. it was a very disheartening point in my career, but I had the wonderful opportunity to play professional soccer with the Atlanta Silverbacks, and I signed a 2-year contract to play with them for 2 years, and I regrouped, took my MCATs over again, and reapplied to medical school and got into George Washington University, where I did my medical school and my PhD. I even went on and did a 1-year postdoc before I started residency at Johns Hopkins University, where I met Alfredo Quinones, the current chair of Mayo Clinic in Florida right now, in Jacksonville, and a deeply close friend and mentor, and somebody who really allowed me to understand what it means to be a physician scientist. If any of you know who Alfredo Quinones is, this is a person who also came from very humble beginnings, jumped the fence to get to this country, worked as a farm worker before he taught himself English, went on to Harvard Medical School, UCSF Neurosurgical Residency, and the sky's the limit. He really showed all of his mentees, as you can see here in this picture, that you have to persist if you want to achieve your dreams. So this one slide really sums up my career thus far, and I'm so excited to be here at UCI, working with Dr. Sue and the team here on seeing what the future holds and how I can continue to advance academic neurosurgery. My advice to you is always surround yourself around good mentors. That's the best way to grow, and persist in pursuing your dreams. Don't let anybody ever discourage you from doing that. If you have the right convictions, be prepared to do the hard work to achieve it. I'm going to talk now a little bit about skull-based surgery, as this is a topic that's very, close to my heart, and I hope it inspires you to consider this as a subspecialty within neurosurgery. From the very inception of neurosurgery, approaches to brain surgery or to the skull base or to pituitary surgery were considered very highly morbid. It wasn't until we learned a lot more about the anatomy and a good surgical technique that we became more facile and more successful at brain surgery. But it wasn't until 1965 that Jules Hardy introduced the microscope for pituitary surgery, where it became an incredible leap forward in technology, in seeing resolution, being able to do microdissection, being very able to do meticulous work in very small, not very well lit places. And to give you a sense of what the microscope is, or what operating through a microscope is for pituitary surgery, I want you to take a look at this video. This is an old video, but it shows the surgeon working through the speculum. And this was a case that I did during residency with a surgeon who continued to operate with a microscope. But you can see here, working through the speculum, being able to see the light source that is providing there at the very end. You see the pituitary tumor being removed with that ring curette and the suction in the left hand. It wasn't until 1996 that the endoscope was actually introduced by several teams, actually working synergistically around the world, particularly in Pittsburgh. Dr. Haidon Zhou and Ricardo Corral, who would go on to be moved to Ohio State and taught me as an ENT the use of the endoscope in skull-based surgery. They introduced the endoscope for the first time in pituitary surgery, and it absolutely revolutionized the way we do pituitary surgery. And the evidence for it really was almost intuitive. The endoscope allowed us to have a very panoramic look at the skull base. It provided dynamic visualization, high resolution 4K endoscopes, and it allowed you to see everything from the frontal sinus all the way down to the C2 base, something that the microscope was never going to be able to show you. And to give you a sense of this integration, I started residency in 2011, and the endoscope, as you can see here, since its inception in 1996, was just taking over in terms of its utilization in skull base and pituitary surgery. This was the first case I did with one at the Stanford New Hospital, and you can see it. This is a panoramic view of our lab setup, or I'm sorry, our operative setup, and how we operate with 4K monitors, endoscope, 2-surgeon, bimanual technique, but it gives you a sense of why the endoscope was so revolutionary in working in this space. And this is one of my first cases here at UCI as an attending. This is a 45-year-old gentleman who presented to me with Cushing's disease and a very small microadenoma right here. And I want to show you, as you can see here we're using an ultrasound Doppler, endonasal Doppler, to visualize the tumor very beautifully there. And then look at the visualization that we see with the endoscope. Angulation, dynamic visualization. Here we're doing careful microdissection as I'm essentially excavating the tumor from the surrounding pituitary gland. As you can see, it's almost the size of a pea. We perform what we call a pseudocapsular dissection, get around the tumor, and remove this tumor all through the nose, incisionless surgery. And you can see here histologically that we've preserved the pseudocapsule, and here's the tumor itself. And as you know from medical school, these tumors can wreak a lot of biochemical havoc. This is the cortisol crash, the characteristic cortisol crash that you see after surgery in these patients. This was the patient when he came to me in referral in December, and he has allowed me to use these pictures very kindly of him. And I just saw him this week in clinic, and look at this dramatic transformation. It's just incredible. And it's extremely rewarding when you know that your surgery and your skills and the training that you've invested in can help people in people's lives like that. And he's incredibly grateful. And I think this is one of the beauties of neurosurgery, is that we get to have this kind of result on our patients. And that result is not always like this, but between the ups and downs, this is very rewarding and something that I think all of you will enjoy. So neurosurgery, or skull-based surgery in general, and particularly pituitary surgery, really falls into these two eras of the microscope and now the endoscope. And for us to be facile with the use of the endoscope and to be able to operate dynamically like this under dynamic visualization, it takes training. And it is the reason why I dedicated a significant amount of time after residency, in addition to just residency alone, but after residency, to learn how to operate in this space and with this technology. And the technology is constantly being advanced. As you can see here, these are 3 different technologies that are currently being studied and researched. This is the use of a fluorescent dye that is taken up by the native pituitary gland, but not by the tumor, to help us visualize and hunt for these tumors. This is the resolution that you see of a 4K endoscope. This is the basilar artery here. And here we are just resected a chordoma and doing microdissection around the microvasculature through the endoscope. This is surgical theater or virtual reality that allows us to preoperatively look at tumors and their relationship to surrounding vasculature and the skull base to help better pre-plan. Here's a video of that ICG that I just mentioned to you and the uptake. Look at this beautiful view here. We inject the patient with ICG in the operating room, and we're able to see the gland, the pituitary gland here, right here, take up avidly the contrast, but the tumor itself does not. You see that? So these are dyes that are currently under research, but we're slowly playing around with them and trying to understand which tumors and what properties allow for this, okay? The other area that's exploding in the field is the use of 3D printing. And what you see here is a very unique landmark case that Juan and I did on a 2-year-old that presented with a very complex craniopharyngioma. We had to print out the skull base. Imagine the size of a 2-year-old skull base, and we had to print out the skull base, and we practiced drilling it to see if it's even feasible before we even went to the operating room and tried to remove this tumor. So this is a technology that, as you can imagine, profoundly changes the way you prepare for surgery. And here's the case live of a case with a large craniopharyngioma. You see the complexity of this tumor. It's how it's wrapped around vascular structures. Here's our view. And here's us taking the tumor out and looking into the ventricular system. You see that? We're actually looking into the ventricular system. This is how deep this tumor was. For a complete resection here. So it's incredible what you can do when you prepare and you are you're determined to do what's best for your patients, and to utilize all this technology in our training. It's just an incredibly humbling experience. I've focused a significant portion of my career on studying of this very unique pathology called chordomas. Chordomas are a bony tumor that has a predilection to grow predominantly in the skull base and in the sacrum of the spine. And traditionally, these tumors, before the use of endoscopic skull base surgery, were very much treated in a very morbid way. And these are what we call Lefort procedures, where there would be incisions made in the face in order to reach the clivus, where most of these tumors are. But with the use of endoscopic skull base surgery, we had direct access to the base of the skull and to these tumors simply through the nose. And of all the pathologies, this one lent itself extremely well to endoscopic endonasal surgery. And I'll show you in this very nice case example of how we treat these tumors. So we go, as you can see here, these tumors, like I said, are very much encapsulating and encasing critical neurovasculature. And in order to do this, you need incredible good resolution, good visualization, and removal of tumors where you can actually use good bimanual technique to remove the tumor without disturbing or ruining or hurting any of that vasculature. I want you to take a look at this piece of data. This is data looking at survival rates across various cancers that are, well studied and appreciated, and looking at their 5-year mortality when disease is local and when it's become metastatic. And I want you to take a look at some of these well-known entities in neurosurgery. So chordoma, 5-year survival rate is almost near lung cancer, okay? It's a very slow-growing tumor, so even when it metastasizes, patients don't necessarily succumb to their disease. But look what happens to the disease at 15 years out. It's essentially uniformly fatal, very much like lung, pancreas, liver cancer, and certainly like glioblastoma. I recognize the need for surgery for this disease very early on, but I also recognize that we don't have very good therapeutics. And as a physician scientist, I'm always looking for challenges and problems to model and try to understand better. And if we don't, nobody else will. If these are our patients and basic scientists are not asking those questions, we're never going to know them. And to underscore this concept for you and the importance that we as neurosurgeons as physician scientists have at the crossroads of patient care, I want you to consider this. This is a undergraduate student at UCI that presented to me in my 3rd week of call here. And she presented to me with significant vision loss. She was progressively getting worse for about 3 months before she presented to the emergency room. She had this large pituitary adenoma. And as you may have learned, that pituitary adenomas can be secreting or non-secreting. She happened to have a secreting one and was making a hormone called prolactin that was giving her amenorrhea, really bad headaches and lethargy. But the point is that this is a tumor that we actually have a very good medication for. And we use a medication called cabergoline. And you have to have faith, even though this patient is presenting to you with, look at these are her visual fields to show you how bad her vision in her right eye is, and the bitemporal hemianopsia that you can see here on the left eye. But simply with just medication alone, after 6 weeks, her vision is entirely restored with cabergoline treatment. And it's very easy to take this patient to surgery and do it, but when you have a therapeutic that does this, it's incredible. And look at the corresponding MRIs. This was her initial presenting MRI, and this was her MRI just a few days ago. Just in perfect timing to share with you in this talk. And you can see what therapeutics can do to tumors. Now, this isn't the only story like this that we have in medicine. As you know, Gleevec is a wonderful drug target that treats CLL. And there are many, many stories and medications that have come out from science to allow us to treat patients. But this is how we have to constantly think. Surgery is not the only solution. And in areas when surgery fails, we have to push ourselves to understand why. And so I was very motivated to understand this disease on a basic science level. This underscores the very poor and dismal survival rates that you see at 5, 10, and 15 years out with these patients. And so I really took to the lab, and I started this work almost a decade ago in Alfredo Quiñonez's lab. We systematically tried to understand and model chordoma. There were no cell lines, there were no animal models. We knew that these tumors were actually born from remnants of notochord that were trapped in the neuroaxis. So essentially, we have these this essentially undeveloped notochord that remains trapped, and this can be a nidus for cancer or transformation. We know this because fate mapping studies finally proved that notochord really can remain undifferentiated and remain trapped within your spinal cord. Here's an example of a remnant of notochord that remains trapped within your spinal column or your bony axis. There's a very important transcription factor called Brachyury that actually regulates notochord development, and you can see it here expressed in these remnants, but not expressed in surrounding tissue. A group in Duke published an incredible study in Nature Genetics showing that duplication of this gene, of this Brachyury gene in familial chordoma increased their susceptibility to this disease. And as you can see here, 100% of patients with familial chordoma have a duplication of this gene. The vast majority of chordoma patients that are sporadic only about a third of them harbor this duplication. Yet, despite that, the protein itself is very much expressed in the disease, whether you have the duplication or not. Now, it's very interesting because the gene for Brachyury actually was discovered a long time ago. And so I searched the old literature, and the gene is actually called the T gene. And it codes for this transcription factor that, as I mentioned to you, is called Brachyury. It's called T gene because when you mutate it in mice, they actually lose their tail. So they named the mice tailless, and hence the gene is called T gene. The transcription factor regulates several stem cell genes. And we asked the question of whether this transcription factor plays an important role in chordoma biology or not. Once the notochord develops and differentiates, it actually is silenced, and Brachyury is actually turned off for the rest of our lives. So we tried to model this disease simply by doing what other systems and other labs have done for breast cancer, for lung cancer, for liver cancer. And we systematically took out tumors, brought them back to the lab, dissected them and dissociated them, and tried to develop cell lines to actually study the disease in vitro. I did this for nearly 6 months, going to the OR, grabbing tissue, dissecting it, dissociating it, and trying to develop cell lines. And for the first time, we were able to develop 2 cell lines that very much recapitulated the disease. And let me show you what I mean by recapitulating it. So these are the cells that grew in culture. They have these very unique fossiliferous features, very much like what chordomas have. So this is a specimen that we took from the operating room, and you can see these bubbly features are hallmarks or pathognomonic for chordomas. And we introduced these cell lines to the literature, gave them names. We even deposited them in the chordoma through the Chordoma Foundation. We received a small grant, and these were the first 2 cell lines that were becoming commercially available for people to study on chordoma. We asked then the next question, and that is the Brachyury protein critical, for the survival of these cells, and how important was it in regulating that biology? So we characterized the cell line, did a karyotype. We started injecting the cell line in animals and showed that we can recapitulate the growth of the tumor. And here you see the xenograft growing in the animal. And you see here a histological view of the tumor from the patient in this panel and the Brachyury expression, as well as the tumor from the animal xenograft, as well as the Brachyury expression. So this was the first animal model that recapitulated the disease simply from the cell lines that we were able to harvest. We next asked the question of trying to turn off Brachyury. And so we used shRNA as well as CRISPR technology to silence the protein. And you can see here from this Western blot, we had the Brachyury protein with a control vector, and this is with Brachyury silenced. We can completely turn off the protein. And look at what happens dramatically when you do that. So here are the control cells, here's the control vector. Look what happens to the shape of the cells in culture. I mean, this experiment was a huge paradigm shift for me, because for the first time, we were able to arrest this disease in culture. This is a proliferation assay showing that when you turn off Brachyury, you almost completely shut the proliferation of these cells down. And then this is a flow cytometry assay showing that the vast majority of these cells, when you turn off Brachyury, shifted from viable to an apoptotic. Nearly 88% were in the apoptotic population. We did microarray studies showing that when you knock down Brachyury, you can see a decrease in the stem cell genes, the anti-apoptosis genes, and an increase in epithelial markers, suggestive of a change in the physiology of these cells. And then ultimately, we did the really proof of concept, and that is we were able to in vivo prevent tumor formation in animals. And here in this experiment, in this proof of concept experiment, we turned off Brachyury in these mice that were harboring Chordoma, and we showed that we abolished tumor formation capacity. So in a span of 10 years, we were able to model the disease, identify a legitimate target, and demonstrate that by turning this off, we can now arrest this disease. And today, there are clinical trials that are trying to target Brachyury through immunotherapy. There are clinical trials trying to target Brachyury through molecular targeting. And I was very proud to be kind of a part of this work, but it taught me so much about how we need to care about our patients and take these challenges that we see, despite the most beautiful surgeries that we can do, and bring them back to the lab to really understand them better. And we haven't stopped there. We're working with a group in Colorado now that have been able to model this disease in zebrafish. And you can see zebrafish are a wonderful model that allows us to genetically provide material to cause mutations that lead to transformation. So here's the zebrafish's notochord. And you can see by injecting these vectors, you can develop tumors very much that look like chordoma, with the exact same fossiliferous features that we saw in the animal model and that we see in patients. So another powerful tool, because this allows us to target or at least develop drug targets and rapidly screen them in this very nice model. This is a volcano plot just showing you some of the gene expression changes that happen when you initiate chordoma in this zebrafish model. So this is kind of my workflow, and it's one that I hold very close to my heart because I am constantly in the OR treating patients, but I realize how important this tissue is to understanding their disease and to developing better therapeutics. And so I'm constantly oscillating between the OR and the bench in order to develop very good models that recapitulate the disease and trying to develop good therapeutics that allow us to make advances in this field. And this mindset was really, as I mentioned to you, something that I adopted very early on in my career and something that I continue to advocate for. And so when I see like-minded medical students and postdocs and residents who have that same passion, I'm eager to have them join our team and push the field forward. So I rely on this kind of mantra that we use patient-derived tumor samples to constantly develop good models that inform us about the disease, and using a combination of really advanced scientific technology through computational biology, through single-cell sequencing, and through genomic interrogation and epigenomic interrogation. The UCI community here is just tremendous, and we've been able to really take one big leap forward with our brain tumor initiative in getting the talents and the scientific expertise from various labs to be part of this big vision that I see for our team. So this is something that I'm going to continue to work on and continue to build here at UCI, and I hope whoever's interested can join me. Lastly, I want to tell you, and I'm going to conclude kind of with these final remarks here before I entertain your questions. I cannot emphasize how important it is in your, or at this stage of your career, for you to find good mentors and to constantly seek their counsel and seek their advice. You don't have to be like your mentors, but surrounding yourself around good mentors allows you. It gives you firsthand view of what a neurosurgeon is. It gives you a very pragmatic view of the sacrifices and the rewards that come with neurosurgery. And because I've been always surrounded by good mentorship, I feel that I've had a tremendous career thus far, and they've imparted an incredible amount of wisdom that I, cherish and take with me from here on out. And I'm honored to be recognized, just recently at the North American Skull Base Society with the Fred Gentili Award, and I share this award really with my mentors, and particularly Dr. Fernandez Miranda, who's helped me, as I said, become the skull base surgeon that I am today. I'm very fortunate that Dr. Frank Su and the team here at UCI have embraced me with open arms and with the vision to push the field forward and build really a continuum of surgical excellence, but as well as scientific excellence. Because if we ignore these diseases and if we do the most beautiful surgeries, but we're unable to provide better therapeutics down the road, we're really doing a disservice to our patients. So with that, I thank you for your attention. I really welcome any questions that you may have. I've written my email address here at the bottom. Feel free to reach out to me if you have any questions whatsoever. And like I said, my door is always open to anybody who's interested in sharing the same vision and the same mission as we move forward in this on this path together.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.